Hello everyone, I'm Chan, and here I'm gonna talk about preliminary results from the study, which is comparative risk of cancer between histamine 2 receptor antagonists. I'm sorry that I'm in the pajamas rather than suit. Please understand me that because it's midnight in Korea now. You may remember before the COVID-19 occurrence in September 2019, there was a very big event in medical society that FDA warned about the probable carcinogen presence of NMDA in the most famous heartburn medication, which is ranitidine or Zantac. Subsequently, ranitidine has been voluntarily recalled from the market. NMDA is classified as a probable human carcinogen based on the results from laboratory tests, and it was also reported that oral intake of ranitidine actually increased urinary excretion of NMDA in human. So if this low dose NMDA in ranitidine increased the cancer risk, we need to recommend vigilant cancer screening for those who used ranitidine, including me and you guys. Similarly, Vasastan, the famous antihypertensive medication, has also been recalled due to presence of NMDA during its production. But the previous reports showed that Valsartan use was not associated with the increased cancer risk in real world, which was published in the BMJ in 2018. So I aim to investigate the cancer risk of ranitidine compared with other H2 blockers. So my study population included those who exposed to one of the H2 blockers of interest longer than 30 days with allowing gaps between the treatment, and I excluded those who used other H2 blockers or those who have the cancer history. The target group was ranitidine user, and the comparator group is other H2 blocker users, including nizatidine, oxatidine, famotidine, and lafutidine. The semaglutide users were excluded from the primary comparator group because I found that there is no empirical equipoise between ranitidine and semaglutide users in previous feasibility study. The primary outcome is overall cancer except non-melanoma skin cancer, and there is several secondary outcome, including overall cancer, cancer death, and 16 types of cancer. And I employed 119 negative control outcomes. In the feasibility study, I found that there is a notch in the early phase of after the initiation of these drugs. So I implemented 1 year lag period or blanking period. So this is the overall scheme for the primary time and risk. You can see that there is a lag period of 1 year after the drug initiation. So follow-up duration or time and risk starts after this 1 year lag period for intent to treat effect analysis or on-treat effect analysis. Because this study has not been completed yet. Here I only show the cohort size, outcome incidence. You can see that overall there is more. I've got the result from the more than 100,000 patients from 3 Korean databases and 2 American databases, and the incidence rate was 17 in ranitidine and 15.5 in other H2 blockers per 1,000 person years. In the negative control outcome analysis showed that there is no low possibility of systematic bias. And I hope you to join the study too. I will close this study soon. You can see every document or the package here, GitHub/OHDSI studies/ranitidine cancer risk. Please join the study. Thanks.